Good morning. This is Steve Steins, Chief Medical Officer here at the University of Kansas Health System, back with you, broadcasting live from the Dolph Simons Family Studio. It doesn't look the same as the last few days when I woke up to the sound of a river going by in the middle of the woods and nothing around, but it's pretty darn good to be back here because this is a great place to be. We are joined this morning by some special guests here in the studio, who I'm going to introduce momentarily. But first, I'm going to turn to Hawkeye.
Hi.
What do we got?
You know, we're doing okay. We're doing better than we were.
I saw the numbers kind of came down. I thought maybe I should leave town more often.
I know. Yeah. Get out. Get out. We were at 20 yesterday. We're at 25 today. Still not bad, but it's a little bit higher than we would like it. 10 in the ICU and 6 of those on the ventilator. So the numbers are we're maybe reaching that equilibrium. Again, it was much nicer when we saw the numbers at 20 in the hospital yesterday. But we do have 30 that are still in the hospital who have gone through their time period since their diagnosis. So not recovered, but still needing to be here, but have been in here quite some time.
So it's kind of like we have 20 that are in the acute phase,
yes,
and we have 30 that are in the convalescent phase, a total of about 50 patients altogether. Yeah. That's still a really big number if you think about it overall of our hospital. You know, if we have 800 or 700 patients in the hospital, what is that? 8% or so of our population. That's still a pretty big number.
And 2 of those are still on the ventilator. So we know that once you get on the ventilator, you're probably on for a little while. So 2 of those who have met that criteria for being here long enough, even as a critical illness patient, are still kind of considered recovered, but still on the vent.
Those are the ones you hate, because those are tough cases. So, all right. Well, we have a very special video to show this morning. It's going to kick off this morning of innovation and surprise from not that our anesthesiology team isn't brilliant, but they've done some pretty cool stuff and developed some pretty cool technology. So let's take a look at the video to start our day.
We're working on a device called the Tent, which is designed to be a portable, affordable, and disposable negative pressure environment in the current pandemic crisis with COVID-19. We, along with many other people, have been looking at ways to minimize the risk to healthcare providers of being exposed to infectious droplets or aerosols, particularly in the world of surgery and procedures.
I think today's test was awesome. I think it gives us real hope that we have a viable product that's going to make a real difference in healthcare, especially during this time of pandemic. The goal was to make a product that's about 2 inches tall when packaged, such that you could put it on an ambulance. You could put 3 or 4 in an ambulance. You can have a stack of these in the ICU. You can pull it out at the moment's notice when a patient needs airway manipulation.
But this is really the only device that we've seen, at least, that combines both the barrier protection, the self-sealing mechanism that it actually seals around your hands as you're doing procedures, the suction aspect to help make sure there's negative pressure and negative airflow during procedures, and the portability that's self-contained.
One thing we thought about early on in this horrible COVID pandemic was this isn't the first time this has happened. Tuberculosis, Ebola, the flu. These type of pandemics are going to continue to come, and COVID is still here. So we want this to be a long-lasting device that really can help people throughout the world.
Ultimately, the goal would be that it's in widespread use nationwide and worldwide even, to help protect healthcare providers during this pandemic and after.
Healthcare providers put themselves at risk every day caring for patients with aerosol disease. And so many of our procedures are aerosol generating. So to have something that mitigates the risk to healthcare providers and will protect patients is just a phenomenal feeling.
So, you know, I was down in the Ozarks this weekend. I was in a tent on a riverbank, no internet, no phone, but my tent doesn't look like that tent. I'm just saying, mine was big and yellow or orange and kind of on a riverbank, and that one's right there in the operating room, 2 inches. Mine's a little bigger than that one. So with us in the studio is Jared Staab, who is one of the developers of that tent. He's going to help us talk about it, I think. And then Jay Noctegal is in Studio B, and Bridget Flynn is one of our anesthesiologists and the head of the Anesthesia Critical Care Program, is in what looks like a sim lab, I'm going to guess. That's not a patient in there who's going to, and I think she's going to talk. So, Jared, would you kick it off for us?
Yeah, absolutely. So thanks for having us on, and we're really excited. This culminates in months of whittling away at this after hours. You know, it really started as it's a tough problem to see your other healthcare workers, friends fall ill. constantly running into, and unknown threats. And, we were inspired by the stories in China and then Italy and then Washington and New York, and, just felt it's creeping closer. We've got to do something. So really, we just started putting this together, started in a garage, and have continued to make improvements there. We've learned a lot along the way and failed forward many times, and we're just delighted that we've got to this point. So that ugly image right there is our first prototype. And
it's not foldable. It looks a little bigger.
It is not. It is not. So we're just trying to demonstrate some concepts, and it's evolved a lot since then as we've learned. So. A lot of the other inspiration, there's my daughter. She will be filming soon, so maybe Jill Chadwick can give her a job someday. But, they always ask, what are we doing to fight the virus? And, right now they think the virus looks like a witch. And, so this was a fun way to help fight the virus, and I think we're going to do some good.
That's awesome. Jay, tell us a little bit about how this even got started.
Sure. We had seen some reports out of China and other parts of the world where people had developed some basic barrier devices made out of plexiglass that could at least provide a little bit of protection for people in the operating room. And but there really hadn't been much in the way of study design and or studies done about how effective or ineffective those might be. And so we really wanted to come up with a concept that was a bit more complete, that really provided a good seal, provided negative pressure, and was easy to use and portable, that could really try to make a difference.
Yeah, that is impressive. And Bridget, I'm guessing you're standing in the simulation lab not just because it's kind of a cool place to be, but I suspect there's part of the story you're going to tell about pitching a tent.
Yeah, definitely.
So talk to us about what's going on.
This is the Contagion Solutions tent. This is the Contagion Solutions tent. So yeah, we are in the sim lab. We have a mannequin here, but you can imagine that this is a patient with a communicable disease that could aerosolize and generate and infect other people, especially our frontline workers. And so by placing them in this negative pressure environment, hopefully all of that's mitigated, decreasing the amount of PPE that frontline workers need and keeping other patients safe and potentially society.
That's cool. Can you show us a little bit about how it works?
Yeah. So this device will come prepackaged at a height of around 2 inches, and then it can be brought up to this size by the novice user in 45 seconds. Negative pressure can be applied right here with any suction tubing from an ambulance, so ambulance workers can put this on in the field if they don't know if the patient has a disease or not. Suction tubing applied right here. If you're in the hospital, OR, ICU, suction tubing will all fit. And the provider who's caring for the patient even has a visual manometer right here that, in fact, that negative pressure is being applied and that hopefully the surrounding environment is safe.
And so the negative pressure means that it's all going into that exhaust, so it's not going out into the atmosphere, because around the patient is, in fact, this negative pressure relative to the atmosphere, I think, as I understand it. And so that way the stuff that patient breathes out is going to go through that suction tubing and out, and not out into the OR environment. But it looks like the patient's wrapped in cellophane around their head. Is that scary to a patient, or what? Tell us a little bit about that.
So
no, in fact, this is completely transparent. And so, the provider can see the patient can see out. It's probably much less scary than other environments. And the provider can also interact with the patient through these hand ports. So if I need to intubate, do a bronchoscopy, endoscopy, anything like that, or just calm the patient, I can do that through these ports and not lose my negative pressure.
Oh, very cool. So, Jared, you started this in your garage?
Yeah, garage.
These are kind of interesting materials to have laying around in your garage there, dude.
Well, this is a lot of fine tuning. In fact, it was a Friday afternoon in a garage, and then ended up as a Saturday morning at the health system here. And so well, I guess now that we're caught. See, I don't know what's worse, that the chief medical officer sort of saw us, smoking in the OR, or that a pulmonologist, saw us. But that was Jay Noctigal doing that, not any of us. But okay. No, so
Jay.
so we instantly knew, we need to do better. We constantly need to do better. So we looked at it from the user experience, the patient experience, a lot of the innovation boxes, very well intentioned and definitely, good at some barrier protection. They still were bulky. They still needed to be cleaned between each use. And so we just went down from version 1 right there all the way to version 5 and made some improvements along the way. So
awesome. And so what's your path for getting into the OR and getting into use it with patients?
So we right now, we've done some preliminary testing, and our next step is going to be emergency use approval. And Bridget, Bridget's our FDA expert extraordinaire.
And it looks like Jay's the patient, which I've got a kick out of this part. This is good. Jay, you make a great patient.
Thank you very much.
Here for you.
And it really wasn't scary. The materials are very transparent. That piece around the neck is very soft and not constricting at all. So other than everybody laughing at me as they did the smoke test, it wasn't bad at all.
Yeah, I enjoyed the smoke test especially. I was trying to figure out, for our audience, which you guys I think are showing, is that even the smoke that goes into the chamber is going out the suction, and there was no leakage around it. So,
absolutely.
Yeah.
Yep.
Good stuff. All right. So Dana, this looks kind of cool to me. What do you think about it?
Is there? I assume there's oxygen pumped in there too.
Yeah, absolutely. So there are several ports that Bridget is highlighting there. So one, there's connections to where we can actually connect an ET tube from the patient to the inside, and then there's an adapter that takes it out to our anesthesia machine or a ventilator in the ICU or an ambulance. There's also inflow ports for oxygen, depending on how much they need, and then ports to remove potential
so you
aerosolized
create an
pathogen.
oxygen-rich environment. It's kind of like having a face mask around the patient.
Absolutely.
This could have a lot of application beyond the ICU. I can see this working in the ICU and other areas.
We've got some ideas.
You're back to the garage, is what you're saying.
Yeah. Well, and we do want to know, how long did it take you to set up your tent?
Yeah, my tent, it may take about 15 minutes or so, 20. I think yours goes up a little faster. I think the tent designers from Big House or whatever it was called could get something out of the Contagion Tent.
Yeah, there you go.
All right. So, Jay, what are your next steps? What do you have to do to get this FDA approved?
So right now the FDA has an emergency use authorization process in place for different barrier devices and protective devices for COVID. So we're in the process of submitting that application, and then it's a matter of hopefully a few weeks to hear back from the FDA and get that approval done so we can start manufacturing these. It's been really wonderful, and I'm sure you've heard about this too, but just through this process of developing this and some of the other projects we've been involved in, that just the charitable nature and the giving nature and the collaborative nature of others here in the health system and in the Kansas City community and state of Kansas has just been incredible. We've actually been working with a company called Biomedical Devices out of Tonganoxie, and Keith Baird has been their lead in helping us produce this prototype, and it's just been wonderful to see everybody coming together trying to protect patients and providers and citizens.
I think that's one of the great stories of the pandemic. If you look for silver linings, part of it is the innovation and the hard work that everybody's been doing to make a contribution to help us end SARS-CoV-2 as a threat to all of us. And I think that's just great work on your all's behalf. So, Jill, let's first see if there are questions out there from media this morning. Not hearing any there, so I bet our listening audience is at work.
They faithfully always have questions. Joanne wants to know, can a dentist use this tent?
Ooh, great question.
So if my wife is watching, she said, why don't dentists use this? And so, but yeah, we are definitely evaluating lots of applications. There's a lot of people don't think of oral care, but that being postponed causes a lot of problems down the road, and even severe medical problems later. So we definitely are looking aggressively at that, and absolutely a great question.
All right, because I can see how this could be applied to a dental thing. And if you think about it, dentists have one of the highest rates of transmission, both to them and vice versa, of any profession. And not a surprise because you're in front of somebody's mouth for a while. So I think it would be a great advantage for a dentist.
Yeah, I think certainly for parts of the exam and parts of the cleaning and things like that, obviously you're going to need a good visual field for that. But I think certainly in parts of that practice, I think it would be very applicable. Just as I think it would be applicable in other places, battlefields, man-made and natural disaster areas, all those types of things as well.
Okay, I'm going to make a really bad joke right now, but at colleges around the country, struggling to get back open and get back on their feet, in part because of some of the social gatherings. I wonder if we could put people in tents at social gatherings. What do you think?
It's really, really lightweight.
Yeah.
And so, and it's portable. So we might have
become
to.
the cool new way to play beer pong. Maybe this is it.
It could be. It could be. I don't
Okay.
know if those cups can fit through those ports, but
Well, you're a smart
we can
guy.
adapt.
Back to the garage.
Modified.
Yeah.
That's right.
Cindy's asking if you can explain FDA rapid approval or emergency approval.
Good thing. Jared?
Yeah. Bridget, do you want to talk a little bit about? Bridget's been instrumental in our
The FDA.
FDA process.
Bless you for working
Yeah,
with
so the
that.
FDA has, yeah, I know. They have a unique pathway during pandemics. So they had one for Ebola, and now they have one for COVID-19, and it's called the Emergency Use Authorization. And so devices that will help society as a whole can go through an expedited pathway through the FDA, a little bit less cumbersome, but only good for the time period of the pandemic, which COVID-19, unfortunately, is going to be here for years, we think. So that's what we're applying for right now, and then we'll go on and get the full FDA approval for life, hopefully.
All right, awesome. So it does allow you to get things out to market faster, which over the weekend had an application with convalescent plasma, Dana.
Yeah, we were kind of unofficially expecting that EUA, that emergency use authorization from the FDA for plasma last week. That got delayed, and then all of a sudden there is an EUA now for convalescent plasma. So, and again, we have been in a clinical trial with the Mayo Clinic. It's been run by Dr. Wissam Elatrini here at the hospital. We've given it to at least 70, if not 80, unique patients as well. I think moving forward, using this in combination with remdesivir, with dexamethasone, with anticoagulation is going to be continue to be better, and we're going to figure out exactly when, because there's a certain time frame after symptoms or after diagnosis that you can use it, just as I think all of these medicines as well. So, but I think that's encouraging. We will still need to get more data. We certainly believe and know that it is safe based on all of the information, but how much of a benefit, that is what we still need to learn. So.
And it's been touted to reduce deaths by 35%. Yeah. That's probably not exactly right. It's if you get it early, you have a 35% chance, better chance than if you get it late.
Correct.
For coming off of the ventilator and getting out of the hospital. So they're actually just getting out of the hospital. So it's you got to be careful how we talk about the statistics, I think.
And it's similar to remdesivir almost in the same way of when are you giving it to severely ill patients, or are you giving it to mild to moderate patients? But we are certainly narrowing down our armamentarium and our timing, and I think we are really making strides as far as treatment.
So it sounds like relatively early, when you get in the hospital and you're mild to moderate, that's when you're going to get remdesivir and get convalescent plasma. Yeah. Okay.
Sue wants to know how soon after FDA emergency use approval will you be using these, and these be available to the public, and are you going to use them here at the University of Kansas Health System?
Well, Jared, you better be using them here if you developed it in your own garage. I'm just saying. This garage thing is going to live for a while, by the way.
That's right. That's right. Really great questions. The prototype, or version 5 that we have there is currently being fine-tuned for mass production and some quality improvements and some durability right now. And we expect that process to take 3 to 4 weeks. So during that time, we hope to get EUA approval, and then it's off to the manufacturing races. So
would you use this here at KU?
We hope to. We hope to.
But you think it's safe to use? I mean,
absolutely.
You get the EUA to do it, but widespread use.
Absolutely. Would you
use it on every patient or just on the people you think have COVID-19?
So one of the things that we go through in the operating room right now is there's a 6-minute time period at the start of a procedure and a 6-minute time period at the end of a procedure that we are waiting for aerosolization to clear the room. So per the CDC, you need 12 air exchanges. So what we can hope to do with this is apply this to patients that are being intubated, aerosolized, or having an aerosolized procedure, and decrease that 6 minutes on the front end and the back end. When you look at OR time, $40, $50, $60 a minute, that starts to add up over the case of several thousand cases and operative procedures per year. So we really hope that this increases throughput. One, keeps patients safe and keeps our providers safe. So, and the other thing, we hope that this decreases or reduces the use of a lot of PPE. That's been in low supply. So for a lot of reasons, we hope to use it here. And absolutely, I felt safe in the one in my garage, and even the one after Jay used it. So,
are they reusable or are they disposable, Jay?
They're disposable. The goal is that we don't have to spend resources cleaning them in between patient uses, but potentially could, depending on the patient's track through the system, could potentially be used out in the field, through the ED, into the operating room, and even in the ICU, and just continue to be applied to that patient throughout that course and then disposed of.
And will you apply them to every patient or only to those who you know are COVID-19?
That's a good question. I think in the current climate, sometimes we don't have test results back, or not everybody has gotten the test. So I would say, at least if we're suspicious or there's no documentation that they don't have 19, that we'd certainly apply it.
Yeah, makes sense to me. All right, Jill.
Barbara kind of was thinking the same thought as you, and she wanted to know if it could be sterilized or recycled.
It sounds like it has to be, it's a single use.
Yep.
Can the materials be recycled somehow?
So as part of the further on fine-tuning design process, we're looking at material that can be recycled.
Oh, that'd be
absolutely.
great. Yeah, so it's not all disposable. All right, because we don't want a lot of containment tents laying around.
That's right.
Yeah, there you go. Or contagion tents. Sorry, contagion
right.
tents.
Right. We have some questions that are a little off topic. Becca wants to know, how safe is it to have young children in a daycare? We're trying to decide whether it's safe to send our 3-year-old to a preschool where the classmates could be as old as 5.
Dana, that's like a $60 million question.
Yeah.
And the answer, unfortunately, I think it has changed even over the last few weeks a bit.
Yeah, it is difficult. So we know that children can have the same amount of virus in their upper respiratory tract as adults. There has been, though, a recent MMWR, which is Morbidity and Mortality Weekly Report, which is a CDC publication that really just came out looking at daycare facilities, and I think it was in Georgia, when they had people where all the adults were masked, the children were masked when they could, they saw a low level of infection, of transmission, but there were also other factors in there as well. So I think we don't know. I think you are right. That is a huge question. We are getting more and more data that, children still have as much virus as adults, but if other measures are taken within the daycare, because this was in daycare settings, they really found a low transmission rate. So it may be safe, but we still don't know for sure, and we are still waiting for all that data.
I mean, for a while we thought that kids didn't transmit the virus. We still don't really know for sure about that. I think that wind shifts a lot, so we don't really know. And then the second question has been, do the kids themselves at risk for that? I don't think the kids get too sick, because even in those situations they have a high viral load. They don't appear to be symptomatic, but that's the trick. They may not be symptomatic, so you don't know. So really, what it sounds like is not too different than what happened down in Springfield with the beauticians in the salon. When the beautician had a mask, the client had a mask, nobody got COVID.
Right.
And it sounds like the same thing's true even in daycare.
I think that's a lot of it. When both parties are wearing masks, that is really going to cut down on the transmission.
And you and I have been to the freezer, so we know what happens with the mask on and the mask off. So got another one of those days coming up soon.
Georgianne says that she thinks your invention is fascinating and will be a great asset. Can you think about designing one for airline passengers?
Oh, Jay, I like that question.
Well, I'd like to respond with Georgianne. We're hiring. Do you want to join the team? So that's a fantastic idea. One of the great things about this in working with our colleagues is all these ideas come out, and so there are several other things we've got on our mind that we would like to bring forth after this. So that could be on the horizon.
I think that airline thing, that is a fascinating question.
Hook a little bubble up.
Yeah.
The oxygen as it comes down.
Yeah. You got your negative flow going out of the airplane. Just have it needs a little monitor so I can watch my video in it. Other than that, it's all good.
That's exactly.
It'd be hard drinking the airplane bottles.
Yeah.
Well, I gave you till October. You got a few days.
Well, yeah.
Don't be slow.
Yeah. That's right. It'll be slow.
Nancy said that she read that 2 NFL teams had a group of false positive tests.
Yeah.
How do they know that they're false positives?
Yeah, okay, Dana. Check that one out.
That is really interesting, too. I was trying to look for information about that. They have kind of gone back to the lab. I think it was basically one lab.
Yes.
I talked with Dr. Leisman, Rachel Leisman, one of our lab directors here. No test is perfect. We have not had any or a large amount, or if any that I know of, false positives, but what they do is have to go back and look at how the test is run. I'm assuming it's a PCR test. I tried to look for that information too, exactly how did they get a false positive. We know that Matt Stafford, the quarterback for the Detroit Lions, had a false positive a couple weeks ago. So I'm not exactly sure, but that's a really good question, and I don't know if you have more insight.
Well, here's what I know. They do saliva testing. I think that was a salival testing. I bet
Okay.
they went back and did some swabs on those. I don't know this. I'm speculating.
Yeah.
But and that's probably dangerous, but I'm betting they did some swabs and found those to be negative, and that would be a gold standard. And so, and I wonder if their controls in the lab pointed to some difficulties, too.
That's what it is. It might be some of the lab rather than actual sample per se, but yeah, both of us don't exactly understand. I think your explanation is good. I was trying to look for that information as well and get a lot of it from the news reports.
We'll try to find it.
Yeah.
We'll keep looking and let you know what we heard and what we learned. Next question.
Denise wants to know regarding the new information on viral load in children, is the reason that they are less likely to spread is because they're not getting sick, so they're not coughing and sneezing?
I think there's, and I talked with our pediatricians here about that. I think one of the things that they had mentioned was, well, maybe they don't have the power to express as much. The other one is, yes, maybe they aren't as symptomatic with the cough, so they're not expressing that much that way. But we know they do like to run around and play. So they're going to be breathing hard after they're running around. They're going to be laughing. That will express it as well. We don't exactly know why, and that's part of the whole question about how well can little children transmit.
Yeah, and I don't think we do know the answer. It sounds like we need to get our team together with our KU Ped and Children's Mercy Peds in the near future for one of our programs and kind of answer some of those questions. How old are your kids?
So they're 7 and 5.
Okay, are they in school or in daycare?
We're starting remotely for school in the Shawnee Mission District, and then they'll be doing some daycare as well.
Yeah.
So.
Yeah, isn't it hard as a parent even trying to make some of those decisions?
Well, it is, and if I try to take credit for any of the difficulty, I'm going to be in trouble when I get home. So no, I think the parents that
you're in
stay
your
home,
garage goofing around with plastic, as far as I can tell.
Exactly. No, I think it's hard on parents. It's hard on parents that are working at home, and it's hard on parents to transition from being a parent to being a teacher. And that's one of the things that we try and weigh and try to find what is the best answer going forward. But it's exciting to try and teach a 7-year-old and a 5-year-old and keep their attention.
Yeah, good luck with that one. All right.
David's got some questions around the numbers that we report. A total of 60 patients. He's wanting to know how many more were past that 2-week period, or did that include the ones that were in the 2-week period?
Yeah.
Why do you divide them up that way?
Yeah, so it's interesting. You'd think we would just report all patients all the time. But actually the way we do it is we report, and we've always reported our acute number, because that's what we report to the government, because that's the government requirement in order to understand what your distribution of PPE and remdesivir and other things that are in short supply. They want to know who are consuming the immediate therapies are PPE for COVID-19. So that's the number you're supposed to report to the government.
Yeah.
We also know that, Dana, that there are people, and I'm calling it anyway, the convalescent stage.
Yeah.
So those first 10 days, you're still theoretically shedding virus. And so that's when you have to be in the PPE. After that, you could come out of PPE,
Yeah.
and then that's the convalescent number. And we traditionally have not reported that because that's not been reported to the federal government. Right. And so we are happy to talk about both numbers and have been in order to be clear to folks. And so that's our total number. So
Yeah, absolutely.
it's 25, 30, and then I guess that totals 55 if I do the
Yeah,
math.
we've only recently started talking about the patients that are still in the hospital but have been 10 days out or more from their initial symptoms or diagnosis. And to your point, it is about the PPE, because the only thing that really is different at that point is you aren't necessarily having to use a gown and gloves. Still, every provider is using a face mask with a face shield or eye protection, which is the goggles, with any patient interaction, whether they're positive or known negative as well. So really it's the PPE burn about the gowns and the gloves. And we haven't traditionally said how many patients were originally diagnosed with COVID that came in but have been here for so long that they meet that criteria where if they were just at home and not ill enough to be hospitalized, they could get back into society based on the CDC or the KDHE requirements. But that's not reported to the government for any specific reason. That's just information for the public that we still do have people here that have since otherwise recovered or got to that convalescent stage of the infection.
Yeah, and I think the other thing is that acute stage, though, those first 10 days gives you a sense of where we are as a community.
Yeah.
If we keep reporting all the other numbers, you're not going to know what's happening more acutely. So we've stayed with that number, as that gives you a sense of what's going on today and going on right now. And the reason why we need people like our anesthesia team who are doing such great work on innovation.
Right. Quinn wants to know, what's the longest length of stay somebody has been with us as a COVID, the shortest, what's your average?
Yeah.
Gosh.
We can let us come back and answer that question more. I know that we
have
people who are here for a day or two, and so that as the crisis has moved along and we've seen it shift from an older population to a younger population, the length of stay has dropped for most folks. I'm not sure the longest length of stay, so let us go find that out. I think our average length of stay is still around 6 to 7 days. So
Yeah, and I thought what Dr. Wild had said was there is that 2 to 3 patient group. That's a lot, and then it dips down, but then there are longer. Obviously, if you're needing to get, if you're having critical illness, needing to get on the vet, that is going to be a longer stay as well.
Yeah. I think one of the things that's been so important is working to keep patients safe, and that's part of what our anesthesia team has done with this. Bridget, talk to us a little bit about the simulation element of that. What happens over in the sim lab there that helps you know that it's safe and that it works?
Yeah, that's a great question, because safety is paramount. We would never want to put a healthcare provider at risk with a malfunctioning device. So we actually had a team come in who actually does all the airflow testing for the KU ORs and the negative pressure rooms at KU, and they tested it for us. And they basically found that we always maintain at least that, or probably a lot more than that per hour that the CDC requires. And so we're happy with that testing. Even with the hands in the ports, we never lost negative pressure.
So really, it's an attempt to work in a simulation lab to make it look like an OR environment, because if it works in the sim lab, you're a lot more likely that it's going to work in the operating room. And Jay, making sure it works and doesn't fail will be important, because I'm guessing you want folks to have to not have as much PPE on and some of the other things, so that means that device has got to be really, really, really good.
That's exactly right. We have to be sure that it works as intended and as designed. And you're exactly right. So many shortages of PPE, whether it be N95 masks, gowns, gloves, surgical caps, our burn through those is extraordinary. And our supply chain folks have done a phenomenal job in keeping supplies up to stock. But we always hear about something that's kind of getting in shorter supply, and we really need to work on conserving that. So this will hopefully help in that regard.
Awesome. All right.
Lori wants to know, should we still be concerned about cleaning our groceries?
Ooh, Dana.
Yeah.
I kind of gave that one up, I'll be honest.
I think we've gotten really away from that. Now, to be fair, when I'm done putting away the groceries, I do wash my hands. It is still a means of transmission. We understand that if you're in the grocery store, if you're anywhere, and somebody is around you coughing, they can certainly deposit the virus onto fomites, which are inanimate objects such as packaging or high-touch surfaces such as rails or countertops. And certainly I would say if it's within 15, 20 minutes of that happening, you're still probably at risk if you're touching that and then touching your face, especially during allergy seasons, eyes, nose. You can transmit the virus to yourself that way. It certainly is less. And we know that once the droplets do land on the surfaces, over time their concentration and the ability to detect replication competent virus or infectious virus goes down as well. So I believe it still is very important to maintain good hand hygiene when out and about, but it is probably less than people being in groups in close proximity for an extended period of time.
Yeah. Okay.
Joyce wants to know, when is the appropriate time to seek medical care to assure you receive maximum benefit of available treatments?
Yeah, that's a great question because you don't want to wait too long, Dana. So
Right.
I know what I tell folks, let's take a swing.
Yeah, I mean, that's difficult because we had just talked about, we believe that these antiviral treatments such as remdesivir, the adjunctive treatments such as convalescent plasma, those things are probably better early in the course of symptoms or diagnosis. But we've also said from day one that 85% of people will not need to seek any medical attention as well. And we are maybe seeing that right now with the decreased amount of hospitalizations despite this recent large increase in cases over the past 2 weeks, 4 weeks. So I think you have to get down to what your body is feeling and how you're feeling. If you are having increasing cough and increasing shortness of breath that is not getting any better, then it's probably time to seek medical care. At what point, do you not have as maybe good a benefit from the remdesivir and plasma? But even that is extended out to be, a week or so from your diagnosis or your symptoms. So you do have time, but I think you just have to listen to your own body and what are you feeling and how are you getting by day to day.
Yeah, and that's what I was going to say, man. If you start getting short of breath, I think that's a big one because that's what really drives a lot of hospitalizations. Or you have any palpitations, or your heart beats a little irregularly, any sort of chest discomfort, or you just can't keep up with food and drink. You need to come into the hospital and come to the emergency room because those are the folks. If that's sort of your threshold, shortness of breath, funny heartbeats, just you don't feel right, and you think, man, I think I'm getting worse. Get into the hospital because we'll help make that decision. We can help triage you, and then we can decide if you need the therapies that are going to work.
And to be fair, I have seen patients that just came into the hospital because they were just having high fever and bad muscle aches, and they couldn't get over that. Their chest x-ray looked clear. They were on room air. They weren't needing supplemental oxygen, didn't have a cough, but they just felt really bad. They came in when their body told them it was time to come in. So, I think it varies, and it certainly is individual to every patient.
All right. Jill, one more question.
All right, Debbie wants to know, she read an article that people who have had vaccinations such as flu or pneumonia shots, they might have protection against COVID.
There's a little bit of stuff out there about how that may help your immune system get revved up, but just a little bit. Pretty uncertain, I think, Dana.
Yeah, thinking about that, I certainly can't believe that. I think there is always something for priming, but you have to understand that most people don't get a lot of vaccinations. Maybe you have your tetanus vaccine once every 10 years. Maybe you're in that high-risk group where you're getting the pneumonia vaccines. Most people have had their childhood vaccines. And in addition, vaccines are a very small part of what your body is able to sample every day and has immune priming with. Anyways, people think that the vaccines are this large thing, but if you think about really how often you get a vaccine, it's not very much, and the amount of immune-inducing substrate in there is very small. There are studies going on now about that, especially things with people who have received polio vaccine or measles, mumps, rubella vaccine. I think overall your immune system is really sampling things from the environment, especially from your lungs, as you know, being a lung doctor and with your CF patients. Every day, that is not a sterile site. You inhale things every day that your immune system has being seen. So I think it's still being looked at. It would be great, but thinking about how many people get vaccines and how often, it seems like it's probably not as
if it is, it's a small amount, and for sure. Well, let's have final thoughts today. about as we wrap up. So, Bridget, let's start with you. Final thoughts. And by the way, congratulations and thank you for the great work.
Yeah, well, thank you for letting us talk about it. We're just very excited that this can help a lot of people save PPE. And, you know, I think it's really exciting where this could go, as all the questions have alluded to.
All right, Jay, final thoughts, and also any concerns you want to raise about Jared's garage.
I've tried to avoid getting caught in there, especially after dark. So just avoid it if you can. But like Bridget said, I think we're very excited about the possibilities of keeping our healthcare workers and patients and society safe, and closer to home, of increasing the efficiency of the operating room so we can continue to take care of as many patients as possible.
Yeah, that's awesome. Jared?
Well, I want to thank Jay that nobody's going to come to my house anymore. No, you know, this was really great. I want to also thank Tim Kraus and Brent Barta, who are physicians on our team that were instrumental in helping get this going, and also a lot of the support. Lydia Allen in Endowment and Dr. Carl Becker helped us out both with advice and financially to kind of get these prototypes done. So it's been really great to be supported by the KU community, and we're just really excited.
Yeah, that is so cool.
Yeah, I mean, it seems like a great device. Again, I think there probably will be many different applications for it, so good luck moving forward, and hopefully we can get it approved.
Well, tomorrow, imagine going through a heart transplant alone during a pandemic. And that is Carol Barnett's story, who wants to share with us how she stays resilient. Her transplant surgeon, Matt Danter, and her cardiologist, Nick Haglund, will also be here to share this remarkable story and offer some insight about anxiety, stress, fear can take its toll on everyone's heart. A quick note. The blood drive over at the Church of the Resurrection in Leawood is open today from 8 a.m. to 8 p.m. and also tomorrow. We need donors. You've heard us talk about this before, and this is a blood drive that's usually really busy, and they have some openings. So, wow, this would be a really great way to connect and help save lives and do the kind of work that Jared and Jay and Bridget have all been doing. So that's a pretty big deal. We got a couple of mask thing pictures to show you. You guys will remember last week I invented a whole new syndrome. We called it COVID weariness syndrome. Cows. And I think cows need protection too. So this is the COVID weariness syndrome protection device. Lori writes, we all need to wear a mask, social distance, wash our hands, and have a little humor to ward off cows. Indeed, how true. Thank you, Lori. Appreciate you picking up that thread because it is very true. And these wonderful new photos from the ministry outreach at New Bethel Church in KCK while folks stayed safe following the pillars of infection prevention while delivering gift baskets to elderly and high-risk patients. Hey, keep sending in those photos. Want to make sure the masking culture continues because it is the best and it helps keeps us all safe. You know, one of the things we'd like to talk about in this program is hope. And I want to say a special thank you to Jared, to Jay, and to Bridget who have joined us this morning and helping us give hope. You know, this weekend I spent time in a tent. It wasn't a Contagion tent on a riverbank. And for 2 days, my friend and I we've agreed it's part of our bubble, and we're floating down the 11-Point River in deep southern Missouri. It's a National Scenic Riverway. It's in the Mark Twain National Forest, and we didn't wear a mask. We did not wear a mask because we're out of doors, and then at night we're on a gravel bar, and there's no bathrooms, there's no share facilities except the gravel bar, and you looked up and you saw the starry sky, and there were no lights. It's just gorgeous. One of those breathtaking times. The moon was faint, and so you could really see all the stars in the Milky Way and the planets. And then the next morning you got up, you're back in the river, you're trout fishing, and it's just this beautiful time, and it felt almost normal. And you know, isn't that what we want to do? We kind of want to get back to being almost normal. I don't know that we'll ever be what we would have thought about was normal, because the pandemic will leave a deep impact on everyone. But I think we can be almost normal. And thanks to Jay and to Jared and to Bridget for helping develop a tool that will help keep people safe and help us get to almost normal, because that's the real treatment for cows. And that's what we need to do. You can help too. You can help us by wearing a mask, by making sure that you keep each other safe, and by remembering that COVID-19 is real for all of us, and that the way we stay safe is that we take care of each other. Until tomorrow, we'll see you then. We have a pretty cool program, as we talked about, with a heart transplant patient being on. And remember, there's still no place like home. We'll see you tomorrow.